Hello, in this lesson I'm going to discuss about basics of toxidromes in pediatrics. Just to define a toxidrome is a group of symptoms that consistently occur together or a condition characterized by a set of associated symptoms. Or we can define this as a group of signs and symptoms constituting the basics for a diagnosis of poisoning. Or in another word, a toxidrome is a syndrome that specifically relates to a specific toxin. When we see toxidromes, it is important. Clinical signs and the symptoms associated with a class of toxins are called toxidromes, and based on autonomic effects of toxin in equation, and based on eye signs, skin signs, secretions, and vital signs that is caused by each toxin, we classify poisoning of different classes and different types into a toxidromes, and this allows a rapid narrowing of our toxicological differential, and it helps us to give antidotes or treatments before identifying the drug that causes the poisoning itself by classifying it to a certain toxin. Currently, we classify these toxidromes into 5. They are symptomatic, opioids, sedatives, cholinergic, and anticholinergic. So let's discuss each of them separately. The first one is symptomatic. Symptomatics are symptomatic toxidromes. They cause sympathetic upregulation or the fight or flight response. And the symptomatic drugs have mnemonics. We should, if a patient or a child is poisoned by a symptomatic drug, there is a classic symptoms that they show. From this, we can remember them by mnemonic: matis, mydriasis or large pupils, agitation or arrhythmia and angina, tachycardia, hypertension, hyperthermia, seizure, and sweating. So symptomatic drug, all different symptomatic drug causes mydriasis, agitation, tachycardia, hypertension, hyperthermia, seizure, and sweating. And the most common drug that causes symptomatic toxidromes are stimulants. From the stimulants, cocaine, amphetamine, caffeine, and the like. There is no single drug that is used as an antidote for symptomatic poisoning, but we can treat the patient supportively. From the supportive measurements include IV fluids, and they have hyperthermia, so cooling therapy is important. And if they are sedated, if they are overstimulated, we can give sedating drugs such as benzodiazepines. If they have seizures, benzodiazepines or phenobarb is important. If they are hypertensive, we should have to give antihypertensive drugs such as nitroprusides. And even benzodiazepines may help to reduce the hypertension. And also for chest pain, we can give nitroglycerin, aspirin. And the other thing is we should have to avoid beta blockers and monitor for rhabdomyolysis. So the treatment is most of the time supportive. But these symptomatic drugs are they have short half-life, and most of the time they will give away, or the patient will improve by itself rapidly. The second class of toxidromes are opioids. Opioids are a class of drugs which can cause sedation and respiratory depression. So they are well known for causing sedation and respiratory depression. There are two classes of opioids, natural and synthetic. Natural opioids include morphine and codeine, and synthetic derivatives are so many. They include heroin and fentanyl. They act at different receptors such as mu, delta, and K receptor, but most of them act at mu receptor, and those opioids act as agonists to this receptor, so they stimulate the action of the receptors. When we see the mnemonics for remembering narcotic or opioid toxidromes, we can use CPR3H. They cause deep coma, they cause pinpointed pupil or meiosis, they cause respiratory depression, they cause hypotension, hypothermia, hyporeflexia. So this is the opposite effect of that of symptomatic drugs. Symptomatic drug causes hypertension and hyperthermia, whereas this causes hypotension, hypothermia, and respiratory depression. And also symptomatics causes dilated pupils or mydriasis, whereas this one causes pinpointed pupil. But from this, meperidine will not cause meiosis. So these classic symptoms are not common for all opioids, but those symptoms are the signs and the symptoms are seen on most opioid poisoning. Narcotics have antidote. The most well-known antidote is naloxone. We should have to start with minimum amount and titrate the dose every 2 to 3 minutes as needed based on the patient's response. So naloxone is an antidote for narcotic poisoning. Whereas the third one is sedative hypnotic. These are a group of medications that causes GABA receptor agonisms. They cause CNS depression, and the most common sedative hypnotics are benzodiazepines, including lorazepam, diazepam, and the like, and alcohol. These are CNS depressants. But even though their symptoms look like that of the previous one or opioid one, they doesn't act at opioid receptors. They act at GABA receptors. They cause GABA receptor agonism. Sedation is primarily hallmark. Somnolence, loss of airway, protective reflexes may occur, and also respiratory depressions may occur. And autonomic effects are minimal, but if it occurs, it might be due to congestion. Most of the time, we manage sedative hypnotics supportively, so supportive care is enough for most patients. But for those who go too much to benzodiazepine poisoning or benzodiazepine sedation, or for young children, we can give flumazenil. It's an antidote of benzodiazepine, and it's not given often because it can induce withdrawal seizure. But we can consider it for children and for those who go too much to benzodiazepine sedation. The fourth class is cholinergic poisoning. This is due to excess of acetylcholine activity. Typical agents include pesticides and nerve agents, and they cause parasympathetic response and rest and digest like action. And they act at a nicotinic acetylcholine receptor in the skeletal muscle and the muscarinic acetylcholine receptors in the CNS, heart, exocrine gland, and the smooth muscle. And most agents work by inhibiting acetylcholinesterase inhibitor. So this causes excessive activity of acetylcholine because of inhibition of acetylcholinesterase as the neurotransmitter junction. They causes overstimulation. They cause different activity as other groups on a different organ system. They cause bradycardia. They cause low blood pressure or normal. They cause sinus bradycardia. They cause respiratory depression. Temperature may not be affected, and they cause miotic eye or pinpointed pupil. Overall, we can remember it by mnemonic, dimples, and muscarinic receptor can be remembered as sludge, salivation, lacrimation, urination, defecation, GI cramping, and emesis, whereas nicotinic symptoms can be remembered by MTWTF, muscle cramps, tachycardia, weakness, twitching, and fasciculation. But the most common symptoms are due to muscarinic poisoning. We can remember it by dimples, by mnemonic dimples, diarrhea, urination, meiosis, bradycardia, or emesis, lacrimation, lethargy, and salivation. So the treatment of cholinergic poisoning include initial treatment is with atropine, and the dosing is based on the type of exposure and also based on the patient response, and the treatment is until secretions are dried, and the benzodiazepine can be used if the patient has active seizure. Lastly, we can inhibit the nicotinic effect through by giving pralidoxine antidote. The fifth type of toxidrome is anticholinergic. Those anticholinergic causes blockage of acetylcholine binding to postsynaptic receptor, mainly at muscarinic receptors at peripheral and central sites. Those toxins, they are found in nature most of the time, and those toxins opposite they cause opposite of the effect of the cholinergic poisoning, and they act as the same receptors as cholinergic receptors. The common agents are anti-Parkinson's drug, antiemetic, mydriatics, antispasmodics, and also certain drugs can cause a secondary effect of secondary anticholinergic effects such as antihistamines, antidepressants, antipsychotics, herbal supplements, and antiviral drugs. And anticholinergic drugs have also their own effects on blood pressure, heart rate, cardiac rhythm, respiratory temperature, eye, skin, and secretion. And overall, we remember them by those things. They have mild rashes, non-reactive to light, dry mucous membrane, flashed skin, urine retention, altered mental status, tachycardia, constipation, and absence of diaphoresis. Most of the time, treatments are supportive for anticholinergics. For example, if the patient is seizing, we can give benzodiazepine. If the patient is desaturating or hypoxic, we can give them oxygenation and also ventilation. And we can also try giving physostigmine and caution patients who may have overdosage of tricyclic antidepressant. Important. In summary, those toxidromes have different effects on vital signs, pupils, skin, and the mental status. So based on this chart, for example, opioids cause decrease in respiratory rate and the pulse rate, and also blood pressure. Whereas anticholinergic cause opposite effect. They cause increased heart rate, blood pressure, and the temperature. And sedative hypnotics doesn't affect vital signs most of the time. Sympathomatics, they have this almost similar activity to that of anticholinergic regarding vital sign. Anticholinergics cause dilated people, and also sympathomatics cause dilated people, whereas opioids and the sedatives cause most of the time constricted people. So based on our vital sign, patient's vital sign, pupil size, and the skin condition, and also mental status, we classify the cause of the poisoning into certain toxidromes, and we can try giving antidote and also supportive treatments. Thank you. Please subscribe this channel, and thank you for your attention.